So, so I'll just give the starting remarks. Our first web session of this academic year, and due to the unfortunate absence right now for today's meeting of our President Dr. Ashish Patil, because of unfortunate incidents in his family, I would like to hand over the mic to our President-elect, Dr. Ajay Bhandarkar, sir, to please declare the meeting open with his few initial remarks. Dr. Ajay Bhandarkar, sir.
Hello, hello, good evening, everyone, and greetings from on behalf of our president, and we convey our condolences to the family, and we start our job. And one of the excellent topic is which is being planned by Prashant Mulaukar and Ganpule. And unless we make an effort to publish our data, we don't realize the importance and toughness in publishing or getting it published in the reputed journals. So whatever hard work and efforts are being done by the faculty as well as the council, I wish that everybody makes a good use of it. And I congratulate all the organizers of this excellent program and declare this webinar or a teaching program with an followed by e-certificate is an excellent idea. And I wish all the success to all the speakers, and I wish that everybody benefits from this topic. These topics being discussed here. Thank you, Rajesh, for involving me, and thank you, Prashant. And I request all of you to take it forward.
Thank you, Ajay bhai. Thank you. Just on a lighter note, Prashant, are there any passing marks in your exam today?
No, there are no passing marks as such. The questions are very easy. The purpose of keeping the exam was that at least those who attend the session will try to judge whatever they have understood. And we also try to judge whether the message is carried across properly.
Sure. Great job, Prashant. You and Arvind are doing a great job. Please start with the topics here. Let's go on.
Yeah. First of all, I welcome the editor of Indian Journal of Urology, Dr. Apul Goyal, for this session. And this is the first session of the current body. The main purpose of having this session was it is either you publish or you perish. And although we have a lot of data with us, unfortunately, we are not publishing the way we should be publishing, and also we are not analyzing our data. And it is the main motto of the Urological Society of India as well as the Urological Society of India West Zone is academic upliftment of the members. So with this in mind, we have planned this activity, and I hope that most of the members will get some good inputs from this meeting and will publish their work. With this, I call upon Dr. Apul Goyal for his opening remarks, and after that, we'll be starting the actual session.
Thank you for organizing this session and inviting me as one of the speakers in the second session, which is after 1 week, and for asking me to give the opening remarks. So I think I've seen the agenda and it's quite comprehensive. 2 days, 2 hours. It's fairly comprehensive with very excellent speakers. So I wish all the best. I think it will be a learning experience, both for the students who have joined us, maybe the residents or the younger faculty members, and also for all of us, actually. It's a learning process. We keep learning. We learn on the job, as we say. So let's hope that we enjoy these 2 hours. Thank you so much.
Over to you, Dr. Arvind.
Thank you very much, sir, for being with me in this session. So, without wasting any further time, I would like to invite Dr. Gagan Gautam. I think that he doesn't require any introduction to anybody in this group. He is an accomplished robotic surgeon, and more than that, he is my friend and a colleague in the Indian Journal of Urology editorial board. He is going to talk and give us an overview of research, the type of studies, study design, and the research process. Over to you, Gagan.
Thank you so much, Arvind. It's really an honor for me to be here and to be, the opening batsman of this wonderful session. Are you able to see my screen, please?
Yes, perfectly.
Excellent. So just in case my screen freezes or something, let me know. I think it's working well, right?
Sure.
So I'm going to start off with my mandate, which is to speak about an overview of medical research. I don't have any relevant disclosures except for the fact that a lot of things that I'm going to talk about are some things that you probably already know. And it's probably better to take one step backward before we start on this journey, which will culminate after 1 week. And there are some excellent speakers, excellent colleagues and seniors that I have who are going to, take this journey forward. But I'll just start off with the very basics. So medical research is, of course, a systematic process aimed at advancing healthcare by investigating conditions, treatments, and outcomes. While we may look at the importance of medical research at an individual level, but medical research is equally important at a population-based or a global level because that is the only way we are able to implement the healthcare policies, find out where the needs are, and implement the programs that are required on a large-scale population basis. When you talk about, you can look at the types of studies in various different ways. Like, for example, basic science is a lab-based research, whereas clinical research actually involves patients to address specific health issues. You can also look at types of clinical studies as observational and interventional. In observational, of course, we are not doing any intervention. Like, for example, we are trying to find out risk factors for prostate cancer in a population. For interventional studies, there is some kind of an intervention, whether a surgical procedure or a medication or a device or something to look at things like, for example, impact of enzalutamide on progression of CRPC. So there is something being done actively in an interventional study. If you look at various observational study designs, the last one, case series, but let's look at the first three. If you look at the cohort studies, the most important thing in identifying what is a cohort study is to look at the direction of inquiry. By that, I mean that in this particular situation, you are looking at exposure first, and then you are checking for the outcome based on that exposure. For example, if you want to find out that what is the impact of smoking on bladder cancer, or what is smoking a risk factor for bladder cancer, you can start with a population and you can look at the exposure over a period of time, those who are smokers and not smokers, and then kind of try to figure out whether in each group what is the incidence of bladder cancer. So that would be a cohort study. A cohort study, like I have described right now, can be prospective, where you're looking ahead, you're looking at the exposure over a period of time, say from 2024 to the next 10 years, and then looking how many people develop bladder cancer in 2034, for example. Or it can also be retrospective. But the direction of inquiry is always from exposure to the outcome. So if you go to a population and you, based on the data that you have, based on medical records, based on the questionnaires, you try to find out that how many of that population over the last 10 years have been smoking. And then after that, you try to figure out, okay, how many have developed bladder cancer over the last 10 years? The direction of inquiry is still from exposure to outcome, but it is a retrospective cohort study. Now, this is in contrast with a case control study. In a case control study, the direction of inquiry is from the outcome to the risk factors or to the exposure. So, for example, you go into a population right now and you divide that population into patients who have bladder cancer and patients who do not have bladder cancer. And then you retrospectively look at whether how many of them were exposed to cigarette smoke or not exposed to bladder smoke in both these hands. So here you already have an outcome and you're trying to look at the risk factor. So the difference between a retrospective cohort study and a case control study is subtle, but the direction of inquiry will tell you which one is which. Now, if you look at a cross-sectional study is just happening at one point in time. So you go into a population, you see how many have disease, how many don't have disease, how many have a particular factor, how many don't have a particular factor. So today you go into a population, you find out how many have bladder cancer, how many don't have bladder cancer, and then how many are smokers, how many are not smokers. And this will be a cross-sectional study, and then you can draw your own hypothesis and associations. It will never prove causation, but associations will become more clear. If you contrast it to a longitudinal study, like a cohort study, a cross-sectional study has data collected at one point in time, whereas a longitudinal study, data is collected repeatedly, exposure is evaluated repeatedly, and then an outcome is looked at. Now, let's look at some interventional study designs. Now, in interventional studies, there are these whole bunch of different study designs which one can follow. And in interventional study designs, the most popular and the most well-known would be a randomized controlled trial. It is the best way to avoid bias because participants are being allocated randomly into different groups. In a parallel group, once a participant is assigned to one group, he stays in that group. In a crossover design, the participant can be both the intervention and the control. So the participants will cross over from one arm to the other. In a cluster randomization, you are not actually randomizing individual patients, but you are randomizing the communities or hospitals. So it may be logistically easier to do when it's a very large study, but the randomization occurs at the levels of groups of patients rather than individual patients. And of course, examples can be a million when it comes to RCTs. Sometimes randomization is not really feasible or ethical. Now, suppose, for example, you are a strong believer that robotic partial nephrectomy is the best. You introduce a robot in the hospital. Now, all partial nephrectomies that you want to do are robotic. So you can have a comparison between the patients that were operated before by an open surgical technique, and now you can compare it with the robotic surgical techniques. There is a greater chance of selection bias in this kind of a situation. It is non-randomized, but it will still give you some information. In a single arm trial, like for example, early phase trials, phase 1 to assess feasibility and safety, there is no control arm. So that's easy. In factorial trials, there are multiple different arms. So you may be testing different medications for the same condition. You may be testing different doses. You may be testing a combination of medication and some kind of other physical intervention. So you will have different arms within the same trial with one control group. In an adaptive trial, that allows for modifications of the protocol over a period of time. So for example, suppose some new medication is introduced, so that with the new medication, the standard of care can change. And one easy example in this situation is the STAMPEDE trial, which is common knowledge for all of us. Now, in this STAMPEDE trial, which is a multi-armed, adaptive, factorial, randomized control trial, you have changes in medications, introduction of new arms over a period of time. Even the standard of care has changed. For example, in 2005, when it was introduced, the standard of care was just androgen deprivation therapy for metastatic prostate cancer. And then in 2012, when it became known that docetaxel is useful in this situation, the addition of docetaxel also became a part of the standard of care, which is the control arm. So this adaptive design can help without compromising patient treatment over the long term. In a stepped wedge trial, everybody gets the intervention, but over different periods of time. So you may introduce a bladder cancer screening program in one clinic at one time, and then after a year you can introduce in the other clinic, and then one can act as a control for the other. Similarly, it is important to note the difference between equivalence trials and non-inferiority trials. Now, in equivalence trials, we are trying to figure out whether these two treatments are equal. For example, you may want to test a generic medication against a branded medication, and you want to say that these are just basically the same thing. In a non-inferiority trial, we just want to look at whether this particular treatment is not inferior to the other treatment. So, for example, if you want to look at in terms of the differences, we just want to prove that it is not worse. It can be better, it can be the same, but it should not be worse. That's the only thing we're trying to prove. Whereas in a equivalence trials, we want to make sure that it's neither superior nor inferior, it's just the same. Now, the phases of a clinical trial are also something that is basic knowledge. I think all of us know about it, But just to quickly revise, now preclinical testing is phase 0. When you look at a very small group of participants to assess the safety of the dose, and you want to look at the pharmacodynamics and the pharmacokinetics, you do an initial phase 1 study. Phase 2 study is to evaluate again a slightly larger group of patients. You want to evaluate not only the safety of the particular effective dose, but you also want to have some kind of an evidence that the medication is actually working. Phase 3 is when you're on a larger group of patients, you are comparing the effectiveness of that medication invariably to the effectiveness of other standard treatments that are particularly available. Now, a lot of phase 3 studies are randomized control trials, but it's not necessary for phase 3 to be a randomized control trial. It can also be a non-randomized study. But most commonly, you would identify a phase 3 study as an RCT. And then a phase 4 study is when you look at the long-term side effects and safety of a particular medication or an intervention after it has already been approved, after it's already been introduced into the market. Now, before I sign off, I just want to briefly touch the research process, which is basically the process by which new knowledge is generated. Now, these are some key characteristics of this. It should be systematic, objective, it should be logical, it should be based on observable evidence, and you may require revisiting this process over a period of time. Just before I sign off, I just want to tell you that these are the broad steps of research process, and each of them invariably has its own lecture, has its own kind of talk in this week and the next week. So of course, my learned colleagues will go take you over these various steps, but the beginning is to identify the problem and to evaluate the current literature that we have, create a hypothesis, design a research using these types of studies. We do a description of the population that we are going to address. We collect the data, we analyze it, and then we finally write the report. So these are the sequential steps that one has to follow during the research process. And just before I sign off, I would like to just say that probably millions and millions of lives have been saved by medical research. And I think in our own lifetime, there has been such a definite advancement in medical research that we can never underestimate it, and we can never overstate it, that medical research actually plays a role not only on an individual level, but also to provide happy and healthy life at a global level. Thank you very much for this opportunity.
Thank you very much, Gagan, for that very lucid talk. I know it's a very dry topic, but you have made it very interesting. We have got time for 2 questions. I'll ask one question and ask the audience for if they have got any. My question was that if there is a randomized control trial, number one, is it mandatory to have it registered with the RCTI? And if so, how should the investigator go about it?
Well, to be honest, I would like to pass this question on to somebody else because I'm not really sure how to answer it. I think an RCT needs to be registered. I think that's for sure. But what is the process? I'm not really sure about it.
I think we have got Apul sir with us. He can actually answer that question because this is a very common thing that comes when we review articles.
Yes, it has to be registered. I am also not sure. I forgot that organization because we register it. I have registered myself. My residents do it actually. I'll have to find out
clinicaltrials.gov. I think that's where you have to go.
CTRI, sir.
But
CTRI.
I am not sure whether it's an Indian site or not.
No, it's Indian site is available. I have registered one of my trial with that. It's CTRI, sir. Indian site is available. I'll search the address bar of this thing and I'll post in the chat group.
Yes.
Yeah.
Yes, I think
even for systematic reviews, if you are doing a meta-analysis, then also it has to be registered.
Great. I think we have got one question from Kochikar sir. Sir, you can unmute yourself. Unmute, sir.
Yeah.
Yes.
Hi, Gagan. Excellent talk as usual. And congratulations to everyone. It's a fantastic program. Gagan, one question for you. See, many times, the conclusion, for example, the trial is something like a robotics partial nephrectomy versus open partial nephrectomy. And the conclusion is drawn as it's a non-inferiority kind of trial. I mean, it's like that. So is it the conclusion which suggests that this trial is a non-inferiority trial? Or right from the beginning, you aim at suggesting that we are doing a study to confirm that it is a non-inferiority trial?
I think that we have to, even when we are drawing the protocol and we are designing the study, we have to clearly state that whether it's a non-inferiority trial or whether it's an equivalent study, or whether we are trying to prove the superiority of a particular approach to the other. And the important thing here is what kind of primary endpoint are we trying to address? In most of the minimally invasive versus open surgical techniques, the only thing that somebody is trying to prove probably is that it's oncologically non-inferior. Because it is assumed that from as far as the minimally invasive surgery benefits are concerned, it is assumed that there will be some benefit in terms of blood loss, post-operative pain. Those things are the points in which most of the people would like to talk about minimally invasive surgery. But we just want to make sure that we are not compromising oncological outcome when we are doing a minimally invasive study. So most of these studies would be designed as a non-inferiority study. It is also easier to do. It is also requires less, I would say, statistical rigor and data. And in any case, to be honest, no minimally invasive surgery will ever be oncologically superior to an open operation. It is simply not possible. So if we address the primary hypothesis and the primary question and look at it from a pure logic perspective, non-inferiority study of a minimally invasive approach makes maximum sense.
Thank
Okay.
you. Yeah.
I'd like to add on what
Yes.
Gagan has already mentioned. See, non-inferiority trials or these type of trials are rarely surgical trials. They are usually drug trials. For example, if a company introduces a new alpha blocker, so typically the research design, this you have to do at the very beginning. At the level when you are designing the study, at that level you have to decide whether you want to show the superiority or non-inferiority, because the sample size will be calculated on that basis. For example, if you want to introduce, see, all the alpha blockers are so effective already, for example in BPH. So if you want to show superiority, the sample size would be much larger. If you show equivalence, the sample size would be much smaller, and such type of a study will be more simpler to do, because if you show advantage of 2% or 3% superiority, see, 90% these drugs are already effective. If you want to show a new drug which is 95% effective, then you need a very large sample actually. So typically such trials are non-inferiority. You show equivalence sort of study.
Thank you, sir. Thank you for the inputs, and thank you again, Gagan, for your talk. I would be delivering the next talk, which is on how do we address or formulate a research hypothesis. So, as they famously say that ask a poor question and you will get a poor research. So that is absolutely essential when somebody wants to formulate an research hypothesis. For understanding how do we formulate an exact research hypothesis, we need to understand the life cycle of a research. So this is typical of an life cycle of a research. We first of all need to identify the needs. What is actually the uncertainty we need to identify? Then the next thing is that we need to define the objectives. We need to plan and analyze so as to make that the research hypothesis reaches its fruition, and finally we conclude. So any research question should actually have the following ingredients, which includes addressing a single problem, able to answer all the problems using data collection, have a restricted time limit, provide all comprehensive and detailed results, and most important, it should be relevant and realistic. So what is more important is the research idea followed by the research question. So the research idea provides the basic foundation of a research work, and we all know that without an idea there cannot be a research. So the research idea can only be fructified with an appropriate research question. So remember, we have always been told during our residency and when we are students that an idea can strike any time in the day. And that's why they always say that we should be open to ideas, because if it is a good idea, you will have a good research question. So coming back to the life cycle of a research, we'll go one by one. So what is an study question? So a study question is an uncertainty about something in the population which the investigator desires to resolve by assessing the predefined measured parameters. And what is more important is what lies in between the uncertainty or the unmet need and the actual conclusion of the research process. And that is what actually the research question addresses. And it is very important that the question should be clear, which actually identifies most optimal design and potential outcomes as well. So whenever you want to formulate an research question, what question should a researcher ask to himself to form a good research question? These are the three questions that he needs to ask, which he needs to ask is what is the uncertainty, why is it necessary to address this question, and how we are going to do it. So we'll go one by one. As these are the famous three circles, we always know that the answer lies in the center of these three circles, and that is where the research question should always aim at. To put it very plainly, a research question is a mission statement of the study. It tells us what are we going to do in the study, why and where and how we are going to do it. It sets the frame of reference for the study. So just to answer the first question, that is what. So what it defines is it defines a research problem by clarifying oneself what is the problem and how we intend to solve that particular problem. It can be either descriptive or analytical. Descriptive obviously explores observations, while analytical will address the comparisons, or it will compare two interventions. So we address the next question is that how do we do it? How do we formulate an answer to a particular question? So for that, there are actually two important people. One is the mentor. The requirements for a good mentor is that a mentor should have good observational skills. He should have an ability to search the existing published literature. He should have the willingness to interact in research meetings and discuss amongst the peer. Whenever there is a mentor, whenever there is a mentee, there should be a mentor. He should be able to guide and give an overview of the topic and suggest the concepts. Both the mentor and the mentee need to have a clarity and focus on the nature of the question. They need to have predefined timelines. And the most important thing is that they should have clear objectives on which both of them agree to the same. How do we do this? We do this by having inputs and having measurable outputs. And this can be done by identifying parameters by two defined benchmarks or the frameworks which we are going to discuss. They are the PICOT and the FINAR. It helps to sharpen the initial question and redefine what actually we want to do. Following this, one has to remember that whenever you are going to form a research question, there should be ideally there should be one exposure, one outcome which is very specific. And finally, the hypothesis should be elaborated. A few tips and tricks for formulating the question is that always remember to ask yourself whether it is an open-ended question. Is the scope of the question appropriate and focused? Does it suggest factors which can be measured? Is answering the question always manageable? And finally, is the topic interesting to all the audience at large? Are there any guidelines if you want to formulate a research question? Of course, there are. And these are the two guidelines. They are the PICOT/PEO and the second one is the FINAR. So we'll go one by one. What are the PICOT or the PEO framework? PICOT is the mnemonic for population, intervention, comparator, outcome, time frame. While PEO is for population, exposure, and outcome. So naturally, the question that is going to come in the mind of everybody is what is the difference in the two? And this is the difference. In case of non-interventional studies, intervention variable in the PICOT framework that is on the left-hand side of the screen is replaced by exposure as per the PEO framework. So whenever there is a non-interventional study, it's always better to have an PEO framework rather than the PICOT framework. So if you go into the detail, P means population. Obviously, when you want to go do a study, you need to find the eligibility of the population which you are going to study. What is the size? What is the power of the study? This actually defines the P. Second is the intervention. You need to define what exact type of disease profile you are going to study. Is there a comparable population which you want to study with the targeted population? C obviously is the extension of the intervention, wherein if it is a comparative study, you need to have an equally comparable group. It may be either placebo or a sham intervention. Then you want to understand what is the outcome. And finally, you need to understand what is the time frame. It cannot go on forever. You have to have a completion date and the specifics for recruitment of completion date, date of recording date, and finally the analysis date. So if we define everything, then the question comes, then what is the FINAR criteria? The FINAR is actually an acronym that stands for feasible, interesting, novel, ethical, and relevant. So these are the 5 attributes of the FINAR, and actually these 5 differentiate themselves from the PICOT. So we'll see that in our career, we see many studies which actually which do not reach logical conclusions. And it is because of these things that many of the times the studies that we actually aim to complete, they are not feasible at all. Maybe you might not be having adequate amount of population for the same. The target population may be very minuscule, or maybe it may not be generating interest for the population at large, or it may be not novel, it is just run of the mill sort of things. It may have certain ethical clearances. So what I mean to say that the FINAR criteria actually sharpen the PICOT criteria in helping you to complete the study. So having given this theory, I would like to come out with a few examples which actually tell us how we can apply the PICOT, PEO, and the FINAR criteria. So let's take the example of this, wherein we are going to study mini PCNL versus retrograde RIRS for treatment of 10 to 20 lower polar stones in an RCT. So let's put the PICOT criteria, for example, in this patient. So patients will be P, that is patient that is P would be lower polar stones 10 to 20 intervention would be RIRS, the comparison would be mini PERC, while the outcome would be stone free rate, complications, hospital stay, and the blood loss. So how do the FINAR criteria help us in this particular thing? So let's take a few more examples that how do we fine tune research questions. So let's take the example. As I said, that wrong question will lead to a wrong research. So you can see an example of a wrong question. So the wrong question is, what are the effects of using suction with a PCNL procedure? So if you apply the PICOT, you can see that P population, it is not clearly defined. Intervention is not defined. The comparator arm is not defined, and the outcome, what are the effects? Nobody knows if somebody reads the question. So what would be the right question? The right question would be, does a novel suction through the sheath impact stone clearance rate during mini PCNL in stones up to 2 centimeters? So obviously, if you apply the criteria, you will see that the population is now defined. The intervention is very clear, suction through the sheath. Comparator is very clear, that is the mini PERC without suction. And finally, the outcome is very clear, that is stone clearance rate. Let's take one more example. This question that was asked is starting tranexamic acid before TURP a useful treatment? If you apply the PICO, you will see that obviously first two are satisfied, but the comparator arm is not there. The outcome is also not defined. So a correct question would be, does preoperative 1 gram tranexamic acid reduce blood loss in patients undergoing monopolar TURP? So obviously all the criteria are fulfilled, that the comparator is there with or without tranexamic acid, and the outcome would be blood loss and the complications. Going a bit further, you can see that again, a simple thing like mini PCL versus RIS in TFL, the outcome was not defined in the first. We have just mentioned propensity matched analysis. That actually does not give us what exactly the research question would be. A right question would be comparing SFR and stone fragmentation in patients undergoing these two procedures. Again, we have defined the renal stone burden. So you see in the first question, we have not defined whether it's a renal stone, whether it's an upper aortic stone. So here you see that we have defined it's a renal stone undergoing RRS, and we have compared it with mini PERC in TFL, and again the outcomes are defined. Finally, we'll see how not a wrong question but an incomplete question will produce problems. So this is a question that was posed, that is BPH nomograms using IPSS, prostate volume, peak flow rates, PSA, median lobe protrusion for predicting the need for intervention, development and internal validation. So here the population is not defined. It cannot be in a young patient and a very old patient. Intervention is not defined. Obviously, if it is a population-based study, there will be no comparator arm. But in that case, we should have applied an PEO, not an PICOT. And finally, the outcome is also not very clear. So the correct question would be just modifying it by intervention in men above 50 years in Western India and development and internal validation. So if you go into this, you can see that all the criteria are suddenly fulfilled. And obviously, if it is a good question, the study will also go on very well. So a few common mistakes that we do when we are going to pose a research question is that make sure that it is not too broad, make sure that it is not too subjective or not too objective. It should not be controversial. It should be somewhat novel. That's where the FINAR comes into this thing. It should not be very technical as well. Although this is beyond the scope of my presentation, remember that whenever you are going to do RCT, refer to always the consort checklist, observational case cohort control studies and case control study, it will be the stroke criteria, and meta-analysis, it would be the PRISMA. I sign off by these few take-home messages. A good research question should be focused, but simple, feasible, and relevant. It identifies the unmet need and helps the researcher strategize the plan for mitigating the journey between a problem and the solution. Final four messages are: the ultimate aim should be to have a bench to bedside translation of the data set. So the data set, if you want to be pristine, it's very important that the question is also very good. A right question would satisfy majority of the PICOT, PEO, and the FINAR criteria. A poor question would need reframing before finalization for more apt utilization and completion of the study. And finally, remember that no good hard work will save the work if the original question itself was a wrong question. Thank you very much. We would take any questions if there are any.
I'd like to highlight, Arvind, a wonderful presentation. And actually, this is a very important presentation because this is one of the common mistakes. We see so many theses, and typically they are audits, actually, experience of laparoscopic pyeloplasty at a particular center. They are not really research questions. Making a research question is not an easy job. We daily struggle because we have 6 residents. Finding suitable research projects for these 6 students is sometimes a Herculean task. It's not easy. So, making a research question is a very important thing in any research, the basics. Often I see that the objectives are the aims are too many. So one suggestion would be that keep very 1 or 2 aims and then plan your study. And the second last slide, actually, there's a site called Equator Network. So that also helps all these guidelines, how to, when you are doing a RCT, so the consort, flow and Prisma and all these guidelines are there. So whenever you are submitting your research, ensure that you have mentioned everything. There's a checklist. Some journals, it is mandatory to fill the checklist also, so that nothing is missed when you are reporting your results. So that is also very important.
Thank you. Thank you so much for the input, sir. I think they were very valuable inputs, particularly the checklist thing. The residents should actually note down all these things so that it would be very helpful. We'll move on to the next talk. It is on study methodology, material and methods, patient selection, randomization and bias by Professor Arun Chawla. Chawla sir is the professor and head at the Department of Urology at Kasturba Medical College, Manipal. You know that he is an astute academician, and we are indeed privileged to have Professor Chawla here with us. Over to you, sir.
Yeah, good evening, everyone. Can you hear me, Arvind?
Yes, sir. We can hear you, sir.
Okay, now, okay. Let me just put to the slideshow. Can you see my slides?
Yes, sir. We can see.
So at the very outset, thanks to the leadership of Western USI, Dr. Ashish, Dr. Rajesh Kukreja, and Dr. Arvind and Prashant, who has scripted this program, especially for the benefit of the residents as well as the young members. No disclosures to add, but only thing is, yesterday when I was speaking to Arvind, I prepared the presentation keeping in view to the publication. Then I have little bit changed my presentation to cover the methodology as needed for the research design, and then covered with example in the publication. So, as you all know, can you hear me? Is it okay?
Yes, we can hear you.
Yeah. So, actually, research method is used to find a solution to a problem, while the research methodology determines the appropriateness of these methods applied to a certain solution. So that is important difference between the method and how we apply the method, how appropriately it forms the research methodology. And if you can keep this slide in your mind that describes the various components of research design and methodology, hardly you will go wrong in your research. This is very important slide which I collected from various articles which describe the topic, the question which Arvind was mentioning, the statement or the hypothesis in your mind, the objective of the study, method of investigation, the sampling design, the data tools, the data collection, the analysis, the interpretation, and finally the reporting of the findings. Coming to the material method, the key pillars of the M&N section of the research methodology are the population of the sample or the material. What type of research tool and data collection we need to have, or a population we need to have, depends upon the question as well as the type of the study which you are having. Coming to the tools, it can be a quantitative or the qualitative. The data analysis technique, which include the collection of the different variables, the different demographic factors, and then applying these characteristics, patient demographic, lab, or other values to derive some inference in relation to these variables to your outcome. So this is very important. These are the three important pillars: the population, the research tool, and the procedure, and the data analysis technique. So coming to the material method section, these are the 8 solid components: the overview of the study and design, the population, where it's being done, location, and the study duration, the inclusion and exclusion criteria, the different type of sampling technique, the intervention, the study objectives and outcomes, the randomization and blinding, if any, the data collection, ethical construction. So these 8 components form the important M&M section of the research method. So coming to the first, we all know that I think we've already been covered the different type of study design, the various observational and the experimental study in the form of a case cohort, the cross-section study, and the randomized study, which I'm not going to go in the detail. Coming to the population of the sampling in clinical research refers to the process of selecting a group of individuals from a population which represents the whole. So the important point of taking this sampling remains it should be representative of the whole population. Its size so that it's adequate. The selection which is independent and random, and the type of population which should remain homogeneous. And if you can see the bottom half, it describes in diagrammatic way how the recruitment strategy is planned. You have a target population, and from there you have a inclusion criteria forced on that. You have accessible population. You take the some population out by enforcing the exclusion criteria, eliminate the subjects which are not appropriate for your study, and then you have got a sample. You estimate the sample size and then recruit the minimum number that is good enough to meet the study, and it minimizes the bias and includes the number which can be lost because of non-response and the loss to the follow-up. This is very, very important. Coming to the sampling technique, there are different ways of sampling, but it is important to know that it should be representative in terms of time, place, and person. The common type of sampling method remains the probability and the non-probability sampling. I'm not going into the detail. This can be of further different types. I'll just come to these by taking few studies and trying to elaborate how the sampling is done. It's very important that sample size is actually dependent upon the research goal and the type of outcome you want to achieve. it's dependent upon the confidence level, the margin of error, and the population size. At the same time, you should be very clear about the concept of the 1 alpha and the beta, which represents the positive and the negatives, true positive and the true negatives. It's important that we need to keep in mind the confidence level, the margin of error, and the population size. Ensure that it's a large enough sample which can accurately reflect the broader population while remaining manageable in terms of data collection analysis. So this is very important. And you must know that sample size is determined by your primary outcome bias. And on the right side, you can see that the 2 into 2 the diagram which represents the true positive, the true negatives, and how we calculate the different type of sample size estimation. Coming to the study objective and outcome, it is very important. The fewer the objectives are, the better it is. Usually, the primary objective should be 1 for the study, and the secondary objective should be 1 or maximum 2. Usually, we should try to stick to the very single or 1 objective in the primary. And it should be very clearly phrased and aimed at testing a hypothesis or measuring a quantity. This is very important. You shouldn't be giving a list of number of primary outcomes and number of secondary outcomes. Coming to the intervention, this is very important. If in your study any intervention is involved, you must cover in M&M section the detailed description of the intervention, which should mention all the technical details of the procedure, and if any instrument being used, all the details about the instrument. And if you are reciprocating or if you are doing a study which has already been standard of care and already established, you can always mention that you are carrying the intervention as has been described in a particular as a level of standard of care with a quoting of evidence where it is published. So this is important that it should be described in clear details. Now, coming to the other part of the material method component, this is randomization and blinding. Any study, experiment study which involves intervention should contain a complete information and detailed description of any randomization being done. This is very important that the randomization in any study, it prevents bias and it achieves the comparability between the test and the control groups. And it is the process of assigning the population into 2 groups that each item or subject has equal chance of being assigned to any group. So this is very important if you are taking any intervention where you are planning a randomization. And we all know that there are different types of randomization. You can have a simple randomization. This is just for the sake of description. I put it block randomization. Here you have the patient in block and you allot the test and the control. You can have a stratified randomization. I'll not go into the detail, but these are the different ways of randomization which eliminates the bias. And this is a covariate adaptive randomization. I'll come to the end part of my presentation, which is again a new way of one platform is there where this type of adaptive randomization is being done. Coming to the data collection. Data collection is a very important part of any M&M section of research design or research methodology. It's just a process of gathering and measuring information to answer the question which we have framed, to test the hypothesis and to validate the outcomes. Very important. It should be very precise and accurate. And the key points which we need to be very clear during the data collection is what type of data we are collecting, what is the data source, the data collection method, how accurate is our data, and the integrity of the data. It is very important. Poorly maintained data or poor accuracy of data leads to poor outcome, and the study which will have no conclusion. So what goes in, if the garbage goes in, garbage will come out. That is the common way of explaining if the data is poorly collected. Coming to a very important part of M&M section is the ethical consideration. Is very important to have the institution or any ethical considerations before you are planning any study. should be cleared by the ethical study. And in our setup, it is not only the ethical clearance needed, it is the registration with the CTRI, which is always done before we start enrolling. Even a single patient is not enrolled till the CTI clearance is taken. All the studies which are in the form of dissertation which are done are cleared by the first ethics committee and then submitted to the CTRI for the CTR number. And once we get the CTR number, then only the subjects are recruited for the study. Bias is a very, very important component of amendment section. Actually, in research, it refers to the type of systematic error that can distort the measurement of the results and can affect the investigations and the outcomes. It's important that it can happen in any part of our study. When you are planning a study, during the study design, that means before you have started the study, or during the study when you are continuing with the study, and when you have completed the study, and when you are analyzing the data, trying to put it into the scientific publication at that time. So during the whole progress of the clinical study, you can have these sources of bias in the research. So different type of bias, these are design, selection, procedural, reporting, and the data collection bias. But it's very important that we should try to avoid the selection bias as much as possible by trying to have a clearly defined study population or target population. We should have the prescribed inclusion criteria and the exclusion criteria. And the choice of control group is very essential. And if you are doing a cohort study, the only difference between the test and the control group should be the exposure or the intervention. And if you are doing a clinical study, actually the randomization and the allocation concealment will help in avoiding the selection bias. All these are important and all will correlate depending on what type of study. Part of the research design and the methodology. Here I'm giving a few examples of how we apply the different components of M&M section to the study. This is the first randomized study which I did was the comparison of SMP versus the standard PCL for stone less than 2 centimeter. So you can see here how it clearly mentions the study type, which is randomized control study, the duration for which it will be done, the ethical approval and the registration. It's being done in a tertiary referral center with a clear differentiation to study sample of 2 groups and method of randomization mentioned. It clearly mentioned the inclusion criteria and the exclusion criteria, precisely the participants. It has clear indication of who will be doing the procedure, and the procedure has been mentioned clearly in the detail, both the SMP as well as the standard PCNL, the concert diagram, the intervention described in detail, and the detail which is more reproducible universally, and the sample size, how it was calculated, and the performing the various statistical set which will be covered in the next talk, the sample size calculation, and the data to use for different qualitative and the quantitative variables. So this is another study which is an observation study, very, very, this is the study which I read it a few years back, and it's my favorite study, how nicely it has been done. You see that it mentioned very clearly the study designed a 12-month, 2-cohort prospective observational non-randomized multi-center phase 4 being done in a hospital-based urology in the centers. It clearly mentioned where it is going to be done. Independent ethics committee and review board notification has been obtained. Clearance has been done. What is going to be the inclusion criteria? They have mentioned very clearly, and exclusion criteria very precisely and clearly mentioned. How will be the data collected? Description of the data. What will be the tool used in this study, and how the data will be stored. Clear primary and secondary outcomes. They don't have many primary outcome and many secondary outcomes. Very precise analysis of the primary and the secondary outcomes based on the results. The statistical analysis based on the sample size and description of how the data was collected. The clarification of the analysis performed. And this is another systemic review which very nicely depicts the type of bias which can be associated, and the various tools to avoid the bias in the study. This has been described in the systemic review and network meta-analysis published in the European Urology. And this is another study which I just quote again a type of randomized study. It has commented upon the type of randomization, the parameter which are going to be for the inclusion criteria, the blinding as well.
Chawla sir,
Yeah.
can we?
Yeah, so this is again a type of study where I just want to mention that how clearly the M&M section of the research design and methodology has been used by the researchers and whose work has been published in the premier journals. So this is what is the new. This is a magic app. This is a web-based tool actually designed to facilitate the development, update, and dissemination of various research and the guidelines. The new thing which has come because you can't wait for 3 or 4 years for the guideline to come and then you apply your knowledge to them. This is every year being added on this platform, and this is a new thing. And other is the I'll just mention is the platform trial. This is very interesting. This is a type of what I was telling is the adaptive randomized trial. This is something like that, which is a trial which adopts multiple treatment using a single protocol. So if you have a treatment designed for the management of renal stone, you have a standard of care like ESWL, RIRS, and PCNL. You will enter into this platform and keep doing your intervention and putting your results into this. So in at one time, you will have the in this particular position the multiple intervention being done at different centers at a very big platform. This is something which is some sort of adaptive correlated randomized study.
Chawla sir,
Yeah.
Thank
you very much. Yeah.
Thank you.
Sir, that was really very exhaustive and very informative. Just one question I wanted to ask is that suppose we want to publish an case report, is it mandatory to take an ethics committee clearance? And if so, is it something different from an randomized control trial?
Yeah. So in first of all, in a case study, if you have to publish, you need data to be accessed from the patient. So it needs some sort of permission from the review board. So only thing is for these type of studies where you have a case report or case series, you need not have the full board sitting to review your type of study. This can be just given by the secretary based on the type of study which you have, protocol which you have given to them. So one study or 5 different type of patient, you are have cohort of 5 different type of some interesting condition, or 5 different type of advanced procedure performed, or 5 new type of anomalies which you have found during the course of study. So it doesn't need to go to the full board, but it needs to have IB approval.
But
you need to take consent from the patient now. Many journals,
Yeah.
it's mandatory.
So when it goes to the IEB, these records of the patient along with the hospital number will be given to the patient, and the consent form of the patient has to be submitted during the IEB. Documents remain the same.
Got it, sir. Thank you so much, sir, for the talk. It was really very informative. We straightway jump into the next talk. I believe, Malawkar sir, you are going to deliver both the talks.
Yeah.
So first we'll be talking something about literature search, following which we'll be having an interactive session on statistics as well. Over to you, sir.
Yeah. Thank you. I'll just share my screen. I think my slides are visible or not yet visible?
Yes, they are visible, sir. You can make it full screen.
I'm just trying to see how.
Yeah, over there.
Yeah. The slides are visible.
Sir, it's not yet full screen. We can see the slides
Okay.
sorter.
Just a minute. I might have shared the wrong screen probably. I'll unshare and share again. Yes, this will be. Yes, now we can see the full screen.
Yes.
Yeah. So the first topic is literature search. This was supposed to be delivered by Dr. Rajesh Kukreja, but he has some problem in his larynx. So he's using my larynx. So and I got this presentation from him today morning. So it is also possible that something might be missing. So we can pardon for that. Uh, Literature review. Literature search is basically a systematic search for the literature that is available before you start your research work. And the aim of doing a research, the literature search, is to retrieve whatever is available, and it should be thorough, comprehensive, and transparent, so that you do not miss a study which has already been done, so that you do not reinvent the wheel, and so that you get the what are the missing the gaps in the literature. Another thing that is important here is you should also know the you should also access the gray literature, that is the say something like a university thesis or conference publications, abstracts, and all that. Now, how do we do a literature search? Is you have to define a specific subject area which is very focused, and you have to also identify the database where you are going to search for the literature. And then also you have to define a time criteria, that yes, we want a literature from this date to that date, or you want a literature from this particular database, because you cannot get complete literature from all over the world, and doing that will be a very Herculean task. Now, once we do a proper review of the literature, we get an opportunity to revise our research question if some work has already been done, or if there are some gaps in the literature. Now, to do a literature search, also we need to formulate a good question, that we need to have a topic of interest which we are going to search for, and is it relevant to us, and will that literature search add to our research. And another important thing is, from the available literature we can get a good idea about the sample size that we want for our study, and also the inclusion and exclusion criteria. Either we can replicate those inclusion and exclusion criteria from the literature, or you can add some inclusion criteria if that particular population is not been studied in past. So this is the how you form a basis of your study with the available literature. And with the available literature, you formulate a research question, that is PICO, which has already been described by Arvind. So I am not going into detail of the PICO, and this PICO should always be there whenever you are writing a paper, delivering your study. Although you may not always specifically write these things, but this is very important, that what is the population, what is the intervention, what is the comparison and outcome. The time is for some systematic reviews or for some time duration, but PICO should always be there. So again, this is the how do we formulate a research question. This has already been covered. I am not going to go into that. The basic of today's this thing is search technique. To do this search, you should always have proper keywords which are subject specific and which are preferably listed in MESs, that is mesh headings. Because if you have those proper search keywords, then you can formulate a good data or good literature with you. The operators that are used is and, on, or, and narrow, and will combine the two entities. So it will broaden your results, or will also broaden your research. Sorry, or will broaden the research to the maximum extent, and will not broaden it to much extent, and not will be the very fine tuning the literature that you want, so that you do not want this particular population, you do not want this particular outcome, you do not want this particular intervention. So depending upon what you exactly want to formulate, what exactly research you want to do, you have to use this and, or, and not these things, Boolean logic operators. Now, where do we search? We search on Medline and PubMed. Medline is a part of PubMed, and other libraries that are available are Embase, Cochrane, Google Scholar, and Scopus. Now, for a good review of literature, you should at least have Medline, Embase, and Google Scholar. These three are minimum. Of course, you can go on adding the other databases, but these three are minimum. And the PubMed is the most commonly used by everyone. PubMed has got the huge database from 1966 onwards, and there are more than 5,000 journals are listed in PubMed. And in addition to PubMed, you can have a Cochrane database. Cochrane database is basically a lot of systematic reviews are available. Not all the Cochrane databases are available on PubMed, and moreover, the detailness of the data that is available on Cochrane database is much more than the PubMed. In addition, we have got minimal other clinical clinical registries, that is clinical TRI GOV, and the Government of India also website. Now, supplementary search methods. These are, you can have the cross references from the journals that are already articles that were already published. Also, you can get conference abstracts where you can get some other additional information. Also, you can get some unpublished literature, any midterm analysis from the ongoing studies, and the gray literature, that is university thesis, conference proceedings, and other clinical trials and FDA data that is available, because all this data will not be available on PubMed. So, but this will not be your primary literature search. This will add to whatever you have already collected. Now, rating a reference and medical journal, this I am not going to cover because we are having a separate talk on that on the in the next meeting. Here, what we are interested is we should know the what is the impact factor of a journal and what is the H index of the journal. But this will be covered by Dr. Abhijit in the next this thing. Now, coming to which are the high impact journals in urology. They are the Journal of Urology, European Journal, European Urology Focus, IGU, Gold Journal. All these are the journals which are having high impact in urology. Now, why do we need high impact journal? Is because the research that is being published in this high impact journal is quoted in other journals. So the reliability of the data is there. Moreover, then you can get additional information about the same topic, and if other additional population or another additional outcomes are being studied, that will be known to you. Systematic review protocols. Systematic review protocols are basically, I'll come to these things: Prisma, Prospero, and Cochrane handbook. See, Prisma is the methodology of reporting the systematic review, and these are the protocols. I will come to the screenshot later. Prospero is the database where you register your systematic review. In addition to Prospero, there are other databases where also you can register, but the most common is Prospero. Prospero registered and Prospero approved are two different things. You can register any systematic review, but not all. Cochrane handbook is totally different thing. Cochrane handbook is primarily Cochrane will invite the authors for a particular meta analysis. So these are the Cochrane meta analysis. Most of the our common researchers like me and some of the other audience here are basically not invited by Cochrane. So this is how a Prisma flow chart will look like. That is how you identify the records from which databases. Then you screen the records, you search them for duplicates, and then you go for the, basically you read the abstracts and see if it is something is relevant, and then you go to a full text review. And in the full text review, if all the full articles that are fulfilling your inclusion criteria, those only will be included. So this is the standardized methodology of reporting the meta-analysis, that is Prisma flow chart. Now, documentation of literature search, this is important, is when did you search the databases, which articles from which journals were included, which databases, and on which date that particular search were carried out. These are the primarily documentation of the literature search that you have to do. I'll just have a brief review on what are the reference management software. The most commonly used reference management software by most of the residents nowadays is Zotero. Previously, when I was doing this thing, I used to use Mendeley, but Mendeley has been taken over by Elsevier, and now the Zotero is the only free available. EndNote is also available. EndNote is not so easy to use. I think with these, I will stop here and I'll come to the next topic. I think for that, I have to run another presentation.
Thank you, Prashant, for lending your links. Thank you.
Thank you. Thank you. I hope it was okay.
Perfect. You are the master.
My next talk is on introductions to statistics. First disclaimer that I am a self-trained and I am not a very good expert on statistics, but statistics is a very boring for everybody. So I'll try to be very basic in this talk. Most important is I do all my analysis myself. I also get the analysis done by a statistician, and then I try to see what mistakes I have done, what are the why my outcomes are different from the statistician outcome. Then I read about that test, and then I follow what I feel is correct as per my own study protocol. So, and other thing is statistics is a very volatile subject. So before I conduct any test, I will read about what that test is designed for and how to interpret. And that should be always be there because we are not statisticians and we are just consumers of statistical product. And because of that, in this topic, I am going to be this is focused only for the consumer of the statistics and not a creator. Now, why should we know the statistics? Because you get lot many articles, and with the help of softwares, it is very easy for anybody to do a statistical analysis. We have to know whether it is done appropriately or not. That's the most important thing that we should know, whether these tests are appropriate or not. The basic things about what are the variables? Variable is a characteristic or a number that can be counted. It can be categorical or a nominal, like you have got categories like sex, color of eye, race, like that. There is no order that this is first, this is second, this is fourth, this is like, these are just names. So these are categorical variables. Ordinal variables, there is a clear ordinal that TNM stage, T1, T2, T3, or a Gleason grade, Gleason 3, Gleason 4, Gleason 5. These are ordinal variables, but these cannot be summed together. This cannot be averaged. So these are ordinal variables. So we have to know whether it is an ordinal variable or a categorical variable, because you cannot do some of the statistical test with the ordinal variable, whereas a continuous variable is which can be measured exactly. Age can be measured in days, hours, minutes, second. So that is a continuous variable. Weight, body mass index, stone volume, prostate volume, these can be measured continuously. So these are continuous variable. It is a very common mistakes by we people that we categorize those continuous variables, that you categorize stone size from 1 centimeter, 1.5 centimeter, 1.5 to 2 centimeters. If you categorize those continuous variables, what you are doing is your sample size will go down, but the appropriateness of your data will be compromised and you will not get the desired result. So if a study is categorizing continuous variables like this, it's not a very reliable study. Coming to the measures of central tendency, mean, median, mode, everybody knows what is mean, median, mode. I'll come to that in a short while. Normality testing. It is presumed that all the data that is being analyzed is normally distributed. That means most of the content of that data or most of the subject in data will have a mean which is equal to mode, which is equal to median. And most of the data will be centrally placed and the data at the periphery will be very low. So more around 68% of data will be within first standard deviation, 95% up to in 2 standard deviation, and 99% of data will be in 3 standard deviation. To have a normally distributed data is not so common. We try to go near to that. Now, what are the data which are normally distributed but having some variations? To know those variations, you have to know what the two commonest variations is skewness. So a data which is skewed on one side, say suppose you have a data wherein all the large stones are there, so that data will be skewed towards the large stones. Or if the data is having patients with lot many very low PSA values, that it will be the data will be skewed toward the left, like that. Now, what is another thing is this thing is a kurtosis. Kurtosis is the what are the tails of the data. That means whether the central data is very peak at the peak, or the data at the periphery is much more. That means there are a lot many outliers. So the standard kurtosis is 3, and you can also have data with more than less than 3 kurtosis. I am not discussing that. Now, commonest thing that we see in our all research papers is comparing the means. Student test, t-test is the commonest test. It's the most abused and many times misused test, because student t-test presumes that the data is normally distributed. Of course, you can use student t-test if the data is not normally distributed. But if your data is not normally distributed, you should have something called a non-parametric test, which is a Mann-Whitney test. To do a Mann-Whitney test, it is not required that your data be normally distributed. So t-test should be used only if the data is normally distributed. Coming to the measures of dispersion, range, that is what is the first and last value. Interquartile range, when you have a median, then you will not have standard deviation. You will have IQR, that is interquartile range. If you are having median and standard deviation, that means there is some Gochi. Other things I am not going to discuss because of lack of time. These are the this is the how IQR is there. That's the median, and 25% values here, 25% values on that. These are the 1 quartile, 2 quartile, 3 quartile, 4 quartile. So these 4 quartiles, these are basically not the standard deviations, but percentiles. These are percentiles. Coefficient of variation. Coefficient of variation is the ratio of standard deviation to the mean. So higher the coefficient of variation, the greater rate of dispersion around the mean. So your standard deviation should be as nearer to your mean as possible, because if your standard deviation is nearer to the mean, that means there will be no outliers, and your reliability of your data will be more. The reliability of your statistical analysis will be more. Correlation. Now, correlation, again a misuse thing. You have two variables and you try to do correlation, the statistics will give some or the other equation. But that particular equation has no value unless you know how significant is that correlation. If you do a Pearson's test, you will get this R statistics, R square statistic, that you have to calculate a p-value of that correlation by a separate method, and the p-value of that R will depend on your sample size. So in addition to Pearson, you will have correlation coefficients like Spearman's rho or Kendall's tau. Diagnostic and screening test, sensitivity, specificity, positive predictive value, negative predictive value. Everybody knows about this. What a consumer of a article, a reader should know, that the sensitivity is the test when test will be positive when disease is present, and specificity, the test will be negative when the disease is absent. But these do not depend on the population. For us, as a clinician, you have to know the positive predictive value of that particular test or a negative predictive value of that particular test. That will depend on the prevalence of the disease in the population. So suppose we have a X-ray test which is suggestive of tuberculosis, we will always say we can start an anti-tubercular treatment to that patient. But a patient who is from US, they will investigate him further because tuberculosis is not so common there. So for us, X-ray test, cavity, tuberculosis positive predictive value is very high. But if a patient is from US, the positive predictive value of cavity on X-ray test will be very low. Measures of association I am not going to discuss, these odds ratio and relative risk. P-value. Now again, p-value is most abused thing in our statistics. Usually, power of the study. Power of the study. Power of the study is, if the power of your study is 0.5, that is 50%. That means your results are equal to tossing a coin. So you should aim at a power of study which is more than 70%. Most commonly used power of study is 80%. That means the results of your study are valid for around 80% of the times if those are applied to the population. And the last thing is p-value. This is again a very misused thing. Anything which is p-value less than 0.05 is statistically significant, but it does not mean that it clinically significant, because clinical significance of a particular intervention or a drug is a different thing. And suppose you have a drug, you test that drug, it is effective and the p-value is more than 0.05. It does not mean that the drug is ineffective. It means that the evidence that that particular drug or intervention is effective in this population was lacking in this study. That is the interpretation of a proper p-value. And the last sentence, most of the studies are conducted in controlled environment. The inclusion and exclusion criteria are very rigid, and that is not the case in our clinical practice. Your sound clinical judgment should always override a statistical significance of any particular test that you are studying. With these words, I think I stop here. And if there are any questions on statistics, if I know the answer, I will answer. Otherwise, I'll let you know the exact details.
Sir, I have got a question for
Yes,
Apul
sir.
sir, and maybe even Prashant sir can answer it. There are many times wherein when we do the statistical analysis, we see that actually, if you look at the figures, there is a significant difference in two groups, but it doesn't achieve a statistical significance. As an editor, what is the take on this thing? If we say that it is not statistically significant, but it is clinically significant, does that study or statement carry any value? And I wanted to ask Prashant sir as to why they want to decrease that figure to less than 0.005.
They wanted to decrease the figure to less than 0.05 because they want more precision in our studies. So it is not yet approved that it should be less than 0.05, but that's one of the moves.
Okay.
See, p-value less 0.5 means a result coming by chance. So the probability becomes less than 5%. Okay, so the lesser the p-value, the result happening by chance is lesser. Okay, so as was highlighted in Dr. Prashant's presentation also, there are two things: statistical significance and clinical significance. We see a lot of papers, telling that the blood loss in the standard procedure was 50 ml and it was 35 ml in RIRS, for example, or PCNL, mini PCNL, it was 70 ml, 100 ml, and in RIRS 25 ml. So actually, if you look at statistics, this difference comes out to be statistically significant, and often the authors keep highlighting this small difference and keep saying that it is statistically significant. But if you see a difference of 50 ml or 60 ml in blood loss, hardly makes any difference. It is useless actually. Similarly, hospital stay. See, clinically relevant would be a difference of at least 1 day. Someone is going home in 3 days, another person is going in 2 days. That has some relevance, but few hours difference in the hospital stay again is meaningless. So you need to understand the difference between statistical significance and clinical significance. We give too much significance to statistics and not the clinical relevance.
Got it. Got it. So I think Prashant sir, you can go to the last part of the program, that is the MCQs.
Yeah, MCQ. Before that, see, we should consume all the uh, information that is given in the article with our own eyes, and you should always see that whether these results are pertinent to my practice, my patient, my population, and like that.
Yes.
So, as Dr. Apul has said, the hospital stay 1 day, 2 day will not matter much. Doctor, uh, can I start my presentation, Arvind?
Yes, sir. Yes, sir. You can start your presentations.
Yeah. Okay. Actually,
I
sorry,
think
sorry.
Khochikar sir has got one question. I think
Yeah.
you can quickly ask, sir.
Yes,
Hi,
sir.
Prashant. It was quite exhaustive in terms of both the talks. I just want to know, in terms of statistics, at what point you will get the statistician involved? Halfway between your study, at the end of your study, before writing the manuscript? Extremely important.
Yeah. If you're asking me as a person,
Yes.
see,
Or
me as a
otherwise,
person,
what's
no,
the
me as
norm?
a person, usually I require statistics help right from sample size collection. But I will try to do my own this thing. I'll again take his help. I'll do a sample size collection, and then I will have some statistical methodology ready with me. And then I will ask him to suggest whatever is ready with him. Because many times it is not easy for me to explain to the statistician that is what I am measuring. And the results that they give may not be very relevant to my this thing. That's why I do my own analysis. I also use the statistician services.
Many times it happens you do all the hard work. You bring the
Hmm.
statistician at the end of your sort of analysis and your conclusions, and then suddenly you get your sort of way lost, at the end of the day. So, anybody, Dr. Goyal, I mean, what's your take on when do you get the statisticians involved?
Yes. So in a typical thesis, if you a case control study or something like that, you can involve later also. But if you are doing a randomized control trial, because sample size calculation is extremely important, especially the primary outcome. It depends on the primary outcome. So you need to involve any big study, any randomized control study, you need to involve the statistician from the very beginning. Very small studies, then you can, carry with the study, and later on you can involve the statistician.
So with that, I start the MCQ. The link for the MCQ will be on Google Form. Also, I'll be sharing the screen here. The link is already there in the chat box, and I'm also sharing the QR code. Can you see the QR code?
Yes, we can see. We can see
Yeah,
the QR.
you can screen the QR code, and then you will get a Google form. On that you can write the answers. So everybody ready? I'll wait for some time, and then I'll start the questions. Should I start?
Yes, I think we can
Yeah, just
start, sir.
15 questions.
You can start,
So
sir.
which of these is true about RCT? You can key in the answers. Each question I will be giving around 30 seconds. I think that's all. Arvind.
Yes, sir. Sir, will be showing the results to them or the answers?
If you want the answers, I can run the answers, or everybody will be getting the mail.
Okay,
I
okay,
think
then that's
already
fine.
it's 10 p.m.
Okay, so
The questions are very easy, and there is no point in running the answers.
okay, okay, got it, sir. With this, we come to the end of this very interactive session. I feel that this session was the need of the hour, as the buzzword is publish or perish. I would not be repetitive in just running through all the conclusions that have happened in the past 5 talks over the past 2 hours. But I would like to take this opportunity to first of all thank all the participants who have come forward at this time of the day. At one point in time, there were 80 participants, and that's really encouraging the amount of enthusiasm that is there for learning this science. I would be also failing in my duty if I fail to acknowledge the time spent by the editor IJU, Professor Apul Goyal, to give his incisive comments and his valuable inputs throughout. My special thanks to the West Zone Council, particularly President Dr. Ashish Patil, President-elect Dr. Ajay Bhandarkar, and of course our dynamic secretary Dr. Rajesh Kukreja. I would also like to thank all the speakers, Professor Arun Chawla for sparing his time for coming here, and of course Dr. Prashant Moravkar for being such an enthusiastic co-moderator. Thank you all, and we look forward to see you in part 2 of this series on 26th of this month. Thank you so much.
Thank you.
Yeah, thank you. Thanks a lot. We'll be meeting next Tuesday at the same time.
Thank you,
Thank
Prashant.
you.
Thank you, sir.
Prashant, thank you, Arvind. Thank you very
Thank
much.
you.